because the slope is like this. It's only gonna get worse. So unless you stop doing some of these things, it's gonna get worse and you'll be bedridden with fractures and so forth. You want to stop it by doing the recommended exercises, making sure you're taking enough calcium and vitamin. I think that's all I had for the bone part. And if there's any questions regarding osteoporosis and bones. Sir? Question?
Okay. I have a question. To support the vitamin D pills or capsules or whatever, do we need to have some other, like vitamin C or something else?
For the bones, vitamin D, D3 particularly,
Right.
is good. Vitamin C is good for infection and stuff. And if your diet is healthy otherwise, it's okay. You may not take it, but in the winter, especially in the flu season, I take it once every other day because it minimizes the risk of infection and so forth. So the other vitamins are helpful for other things, but for the bones, what you need is vitamin D3.
So you can just take vitamin D by itself?
Yes.
Okay.
Yes.
Because I heard that it needs the support of some kind of protein or vitamin C, one or the other.
Vitamin C, there's a lot of vitamins for different purposes, but if the diet is really good, you can get away with it. But nowadays, especially as we get older, we oftentimes do not have a good diet. So recommended is to take vitamin D3 for your bones, vitamin C in the winter, especially to minimize flu and infections, so forth, and vitamin B for the blood and some neurological condition is helpful. So if you not want to take them individually, the multivitamin is okay. But multivitamin, remember, doesn't have adequate vitamin D3. That's why at our age, I think you should get, in addition, vitamin D3.
And that is for over 70 is 1200 milligram, you said?
1200 milligram, unless you had a blood level done, which shows that you have an unusually low vitamin D level, in which case, some doctors start with a 50,000 units or 5,000 units. But for maintenance purposes, 1200 milligram a day, I end up taking, one pill every other day or so.
Every other day.
But my levels have been normal.
Okay.
Yes, sir.
What's the difference between osteopenia and osteoporosis?
No, sir, you have to come near. I can't.
What's the difference between osteopenia and
It's
osteoporosis?
the same thing. Osteopenia, weakness of the bone, osteoporosis are the pathological term for that.
Oh,
They're the same thing. Penia, whenever you see, is a weakness of that. Anemia, osteopenia. Other questions?
एक क्वेश्चन आपने चार्ट दिखाया था एक्सरसाइज में सैटरडे संडे मंडे
Hmm.
आपने फ्राइडे को ब्लैंक रखा था मैं फ्राइडे को एंडी प्रेयर्स
Pressure. Good idea. Good idea.
ताकि लोग फ्राइडे को प्रेयर्स में जाए तो उनकी बाकी में हो जाएगी
ठीक.
exercise।
That's a good.
आपने ये चार्ट दिखाया था
और
उसके बाद निकला था
Good point. Yes, ma'am.
Is arthritis a reversible disease or can cause or lead to?
My next section is on arthritis, which is a problem with the joints. And I'm going to talk about it. Okay. Anything more about the bones, osteoporosis? No. Okay, we'll go on to. Essentially, it's move it or lose it. Exercise all the way around. It's so important. So we'll talk about joint health and try to make it as simple as I can. Before we talk about the joints, I want to briefly describe the anatomy. What is the structure of the joint? Of course, you have the bone, and on the side there are ligaments that hold them together. Then there's a meniscus or a cartilage, which is like a cushion between the bones, and between the two is a little fluid called the synovial fluid, which is all like a lubricant in the joint. So when you're moving around, you don't feel the bones rubbing against each other because of that synovial fluid and the cushioning with the cartilage. So it prevents it's like a lubricant between the joints. So that is a typical joint. What are the causes of joint pain? It could be arthritis, which is inflammation, which could be infection, which could be rheumatoid arthritis, different diseases that can lead to inflammation.
Meniscus is
Meniscus is the cartilage between the joints, and sometimes there are tears in that, and that can lead to joint pain. And sometimes the ligaments that hold the joints together, they are broken. Typically that happens when athletes and stuff, when they fall like crazy, they have ACL tear and stuff like that. But today we'll focus on arthritis related to aging that is due to inflammation. So as I said, it is a condition caused by inflammation of the joints. In this country, about 27 million people have osteoarthritis, which is arthritis related to aging and inflammation. Gout causes joint pain, 6 million cases in this country. And rheumatoid arthritis is a disease which causes about 1 million cases. But we are going to focus on osteoarthritis, just the inflammation related to aging. By about 45 to 50 years age, about a third of us have some degree of arthritis. At the time we hit 65, almost half of us have some degree of arthritis. Arthritis causes more disability than all the other big diseases like heart problems, diabetes, back problems. Arthritis, joint pains causes more problems, unfortunately. So as I said, it is a degeneration of the joint, the cartilage in the bone between the joint. It breaks down, which is those are the things that cushion the joints between between the bones. Typically affects the weight-bearing joints the most, that is the hips and the knees. But of course, if somebody is using a lot of hand work, they might get it in the wrist and other places too. We're going to focus mostly on the knee joint because that is the most common. Age, obviously, the more we use a joint and scrubbing against each other as we get older, this eventually damages the joint and we get increased wear and tear of the joints, and so you have more osteoarthritis. And again, unfortunately, the risk is significantly higher in females versus males. And by the time you are 65, 70, about, you can see about 75% of male and about 15% of males, about 30% of females. So age, and particularly in females. Obesity. Think about it. The more weight you put on a structure, and the structure is moving all the time for 70 years, obviously the higher the weight, the more trauma there is, the more problem is going to be with the joint. So this shows that as your BMI, the body mass index increases, your risk of osteoarthritis goes up dramatically. The higher the weight, the higher the incidence. For every pound that you gain in weight, adds 5 pounds of stress on that joint, because the two joints, and you have 200 pounds, you're 100 pounds on this area, 2 by 2 inch area of the bones, And imagine that is moving all the time with those 100 pounds weight on it all the time. Eventually, the structures in there are gonna break down. Other risk factor, muscle weakness. Look like you have two bones, one on top of each other, and there's this cartilage between them, and you're moving around. If there's nothing to support them all around, these bones are going to rub on each other. So you have to have the ligaments around them so that even though you're moving around, but the joint doesn't rub against each other. It stabilizes the bone. So you have to have strong muscles and tendons around the bone, around the joint to keep it stable. If it is unstable, if your muscles are weak, if the tendons are weak, the bones, the joints, the bones and the joints are going to be rubbing against each other, and they're going to break down faster. So you need to have strong muscles and tendons around it to stabilize the joint. And diagrammatically, I've shown a nice strong tendons around it keeps the joint stable. A thin tendons, ligaments around it makes it loose, so it keeps moving too much, and there's a higher instance of breakdown and joint damage. Other risk factors is ethnicity. The darker the color, the higher the incidence, and mostly it is in the colder climates over there. In India, Pakistan, there's an intermediate risk, but ethnicity does have a role. Overuse, like athletes and stuff running around all the time, straining the joints more, obviously increases the risk. And there are some families where there's a genetic risk of having a high instance of osteoarthritis. So evolution, how does it progress? Initial stages, you have a nice cartilage, but then gradually it thins out. So you have thinning of the cartilage with a constant pressure. The next stage is the cartilage is completely destroyed between the two bones. So there's no cushioning between the two bones, and eventually what you get is what we call bone on bone. There's no cushion between there. Essentially the bones resting on each other. And like you can imagine, you're moving around, the bones rubbing each other. It's going to be hurting, and it's going to be further damaging that area. And this is just some pictures showing you nice cartilage between the two joints, starting to break down, eventually no cartilage between the joints, and they have bones sitting on each other. That's the last stage of osteoarthritis, bone on bone. And if you look at it on an X-ray, initially there's a normal X-ray. There's a lot of cushioning between the two bones, but eventually when the cartilage breaks down and there's not enough synovial fluid, there's thinning of the cartilage, and eventually the bone is resting on bone. And this will eventually lead to, severe bone damage, joint damage, severe pain and immobility. So management, there are two goals: relief of pain, and secondly, improving the joint function. And management is subdivided into two. It can be non-surgical or surgical. Non-surgical, as I emphasized with the bone problem, exercise being so critical, same thing here. You want to have strong muscles with strong ligaments and tendons around the joint to keep it stable so that there's not that movement, and so there's a lesser risk of damage. So strong muscles improves joint stability and reduces the stress on the joint. It prevents it from moving around on itself. And of course, it helps maintain flexibility of the joint. Weight. I mentioned the weight, even 1 pound increase, it magnifies the weight on the joint, particularly the weight-bearing joint. So even if you lose a little bit of weight, significantly reduces the pain in the joints and improves the function. You can see all the weight. If you even 5% reduction on the weight, it relaxes the strain on the joint and decreases the pain and increases the mobility. So if you have osteoarthritis, particularly in the weight-bearing joints, think about losing some weight will help a lot. Medications are essentially for pain relief. You can use over-the-counter medications like Tylenol and stuff. But remember, Tylenol helps the pain, but it's not anti-inflammatory. You need some medication which also suppresses the inflammation in the area. And for that, you need drugs like Motrin, Advil, and even things like that, which are not only painkillers, but also suppress inflammation. But for those, again, if you're using a higher dose or a longer period, need to consult with your physician because there may be some side effects like gastric irritation and increased risk of bleeding and so on. Of course, if those medications are not enough to control your pain, then you need to go on to stronger painkillers like Voltaren and stuff like that. Again, those are not over the counter. You need to get them from a physician. And sometimes they are prescribing narcotics like codeine and stuff. But again, studies have shown they're not much superior to non-narcotic medication. In addition, there's a risk of addiction, habit formation. So avoid narcotics if at all you can help it. If you need to, use it for a short period of time. If the pain is persistent and medications are not helpful, some would recommend a gel injection. This is like a jelly, like a substance, hyaluronic acid, they inject it into the joint. It's like a jelly, and that would help lubrication. It does help, but it is temporary. It's not a solution. It is only temporizing. It's a symptomatic treatment. It is not a curative treatment. Effectiveness varies by individual. Even though the FDA approved its use for osteoarthritis, but the Academy of Orthopedics is against it because it's a temporizing thing. Gel injections. Nowadays, there's a lot of news about stem cell injections. Stem cells are kind of cells that you get from your own body, from another part, but they have the ability to differentiate into any kind of cells that may be damaged. So if you get those stem cells and inject in your joint, they may become the cartilage over there. So stem cells injections are being used. They help pain relief, they help improve quality of life, but unfortunately today there's not enough studies on the long term. They haven't shown too much cartilage growing there, even with the injection of stem cells. So it's helpful.
It is temporary.
Say that again.
It is temporary, right?
It's permanent.
It doesn't work for a long time.
No, unfortunately, no. That was the hope, that you just inject the cell, they'll make new cartilage, and that's it. You're all cured. But unfortunately, that didn't happen. Supportive devices, helpful for walking around stuff. Heat and cold therapy may help to some degree with the pain and stuff. Ultimately, for curative long-term control of your pain and mobility, joint replacement is the effective thing. Essentially, it is there's three pieces. I'm talking about the knee joint replacement, which are like those, and you essentially shave the bottom of the upper bone and the lower bone, place the two pieces and the cushioning material between.